I am so glad you're here to join me for today's session on MD USMLE Coach Step 3 Made Easy series. I designed to make your USMLE Step 3 review process as simple and effective as possible. In this series, we will be covering key concepts and strategies to help you succeed on the USMLE Step 3 exam. Today, we will be learning key concepts in immunology. So, grab your notebooks and get ready to learn. I am confident that you will find value in the information we will be discussing today. Let's get started. The pop-up question. Young kid around 1 year presenting with repeated infections with decreased T and B cells. You are correct if you said severe combined immunodeficiency. Buzzwords include young kid around 1 year with repeated infections. Leukocyte count in the question can be mentioned as decreased B cells and T cells, or if they want to sound little more difficult, they can mention it as decreased CD19, 20 cells, which is nothing but B cells, and decreased CD3, CD4 cells, which is nothing but T cells. In such individuals, live vaccines are contraindicated, and there is no point of giving inactivated vaccines as there are no B cells, no humoral response to the vaccines. Definitive treatment is stem cell transplantation. Supportive treatment until definitive treatment is antibiotics to treat active infection and immunoglobulins. Pop-up quiz: young boy with repeated pulmonary infections, perirectal abscess and lymphadenopathy and lungs and lymph nodes showing granulomas and culture showing positive to catalase-positive organisms. Yes. It is chronic granulomatous disease. I made the answer easier for you mentioning that the culture is positive for catalase-positive organism. Examiner need not be that good of a person though. So buzzwords here in the question pointing towards the diagnosis would be repeated infections not only in the sinusoidal and pulmonary tract, but also gastrointestinal tract or perirectal abscess. This can help us rule out cystic fibrosis as differential as CF involves only sinopulmonary tract. And presence of lymphadenopathy and lungs and lymph nodes showing granulomas screams the granulomatous disease. Culture shows positive to catalase-positive organism. Look for positive culture to Staphylococcus aureus, Burkholderia, Pseudomonas, Cepacia, Serratia marcescens, Nocardia, Aspergillus. Look for negative NBT and DHR flow tests, which points towards CGD. Prophylactic antibiotic, i.e., trimethoprim sulfamethoxazole, and antifungal, i.e., itraconazole, therapies are required to decrease the risk for life-threatening infections by the most common organisms. In severe cases, immunomodulatory therapy with interferon gamma may also be considered. For a little background, review the flow chart. Deficiency of NADPH oxidase in CGD leads to inability of ROS production, but the granulocytes make use of the hydrogen peroxide produced by the bacteria. The intelligent catalase-positive organisms break down this hydrogen peroxide as well, and so the patients of CGD cannot fight against catalase-positive organisms. Question: a middle-aged patient with repeated sinus and pulmonary infections and GI infections. What test would you do? No high-risk sexual behavior. Answer is quantitative measurement of serum immunoglobulin levels is the next step with such features to establish the diagnosis. As the patient is middle-aged and has repeated infections, the diagnosis can be common variable immunodeficiency, IgA deficiency, and selective deficiency of IgG3. I would like to add few more points about other immunodeficiency syndromes. If the question mentions age of presentation lesser than 4 to 6 months of age, but can be mentioned as later too, and differential leukocyte count showing decreased leukocytes and lymphocyte count and fungal, viral as well as bacterial infections, then it points more towards T cell or combined B and T cell deficiency. Instead, if the question mentions greater than 6 months as the age of presentation as the maternal immunoglobulins protects till then and infections due to encapsulated organisms such as Bordetella pertussis presenting with whooping cough in spite of vaccination, it points more towards B cell deficiency disorders. Neiserial infections in the question should make you think of complement deficiency. Burkholderia, Pseudomonas, Sapation. Don't think of only cystic fibrosis, but also chronic granulomatous disease. Capsulate organism infection, such as strep pneumo, indicates lack of opsonization, X-linked agamoglobulinemia, and complement dysfunction, for example, C3 deficiency. Also take a moment and quickie review to resurface the dormant memory regarding different immunodeficiencies of First Aid Step 1. Pause the video and quickly review the chart from First Aid Step 1. Key points to remember: X-linked B for Bruton's B for boys. B-cell disorders, decreased immunoglobulins. IgA deficiency, anaphylaxis after blood transfusion. A patient who is middle-aged presenting with decreased immunoglobulins, common variable immunodeficiency. DeGeorge syndrome, 3 and 4 pharyngeal pouches defect, absent thymus and parathyroid glands, 4T T for tetany, due to hypocalcemia, T-cell deficiency, thymus absence on X-ray, tetralogy of Fallot or Tunkel defects. Pause the video to go through the table. Points to remember are: SCID also presents with absent thymic shadow, not only DeGeorge syndrome. Ataxia telangiectasia presents as triad, of which two of them are in the name: ataxia, telangiectasia, and third is immunoglobulin deficiency. Leukocyte adhesion deficiency, delayed separation of cord. Chidiac Higashi syndrome. I think the name sounds Gantt and scary, and that can help you remember that Gantt granules are seen in granulocytes and platelets. Pop-up question: a patient who was started on transfusion presents with fever, chills after 2 hours of starting transfusion. What is your diagnosis? Yes, you are correct. Febrile non-hemolytic reaction is the answer, but as it is step 3, there would usually be a follow-up question. What is the type of blood transfused in such conditions? Leukoreduced RBC, as leukocytes having cytokines is the culprit. We eliminated the culprit and give the patient leuko-reduced RBC. If question mentions direct antiglobulin test, which is just the other way of calling Coombs test, positive or free HB25 and fever, chills, flank pain and hemoglobinuria within an hour of transfusion, hemolytic reaction is your answer. Instead, if the question mentions point in anaphylactic reaction, angioedema, hypotension, and respiratory distress, that can progress rapidly to loss of consciousness, shock, and respiratory failure after transfusion, it should point us towards a patient with IgA deficiency being transfused. Plasma contains complements and immunoglobulins. If you wash the RBC and get rid of the plasma, anaphylactic reaction will not occur. So answer is: give them washed RBC. Here you can see the timeline of presentation of different transfusion reactions and also the indications for specialized RBC treatments. Mainly remember that in a patient with immunodeficiency, we give irradiated RBC. In a patient with previous febrile, non-hemolytic transfusion reaction, we give leukoreduced RBC. In a patient with IgA deficiency, we give washed RBC. Question: a child with eczema history now presents with difficulty in breathing with normalization of FEV1/FVC with bronchodilator. Yes, we are talking about asthma patient. Yes, it is step 3, and you can't escape with such simple question. The follow-up question is coming for you. It is: what is the most common trigger? That would be house dust mites, pet dander, and mold, example Aspergillus. HDM accounts for 60% to 90% of cases. HDM control measures, example steam cleaning, upholstery removal, and the use of mite-proof bedding would prevent the risk of further attacks. I would like to just add another point and mention about the presentation of NSAID-associated asthma. Here the patient presents due to excess unopposed leukotrienes due to blocked prostaglandin production. He or she presents with nasal manifestations, for example, polyps, and leukotriene-induced flushing and bronchospasm, and is closely related to medication use, within 4 hours. Pop-up question: a patient had a deep cut with a rusty knife and patient is unaware about her vaccination. Yes, they are asking about the TT prophylaxis requirement. Just pause the video and understand the table. Learning the tetanus prophylaxis guidelines is important. The vaccination criteria depends on if the patient had a clean or dirty wound and if the patient is vaccinated or not. In this particular instance, patient needs both tetanus toxoid-containing vaccine and tetanus immunoglobulin. Patient presents with rhinorrhea, nasal congestion, sneezing, nasal itching, cough secondary to postnasal drip, ocular itching and tearing, and allergic facies. Description. What is the main modality of treatment? Answer is allergic rhinitis. Buzzwords here is the description of patient with runny itchy nose, rhinorrhea, nasal congestion, sneezing, nasal itching, cough secondary to postnasal drip, ocular itching and tearing, and allergic facies. Description: allergic shiners, infraorbital edema and darkening, allergic salute, transverse nasal crease, pale, bluish, enlarged turbinates, pharyngeal cobblestoning, allergic facies, high-arched palate, open mouth breathing. In contrast, asthma presentation description would be wheezing or nighttime cough, making an asthma exacerbation. Of course, the treatment that comes in our mind is intranasal steroids, but here the catch is that they are asking the main modality. Allergen avoidance would be the answer, and intranasal steroids are given only if the allergen avoidance is not possible. A patient who is HIV positive and has a CD4 cell count of 45/μl with CT scan showing a well-defined small focal lesion, biopsy done to confirm primary CNS lymphoma. What is the best prognostic sign? Firstly, when a question mentions well-defined small focal lesion, what comes into your mind? Yes, toxoplasmosis and primary CNS lymphoma. The difference is toxoplasmosis presents with multiple ring-enhancing lesions in contrast to a solitary lesion in the later. Here they have already given you the biopsy result, but are they asking about the prognostic sign? The best prognostic sign is hard-ass improvement in the immune status, example, increase in CD4 count and decrease in viral load, because the degree of immunosuppression seems to be the major determinant of these patients' survival. A child has food allergy to the egg. Is the flu vaccine contraindicated? Contraindications of flu vaccination, DPT, and MMR have to be remembered. Here we need to know that urticarial reactions to egg protein are not a reason to defer influenza vaccination. The only contraindication to influenza vaccination is severe allergic reaction to the vaccine itself. Annual influenza, children age 6 months, mainly patients at risk for life-threatening outcomes, example asthma, chronic illness, age less than 2 years. Inactivated IM influenza vaccines are recommended. The mode of administration can also be asked to confuse you a little more. Live attenuated influenza vaccines, that is the intranasal vaccines, are less efficacious and are not currently recommended. Just to add, the yellow fever vaccine is contraindicated in patients with egg allergy, but not MMR or flu. Patient presents to the emergency department with anaphylactic reaction and is not responsive to IM epinephrine even after 10 minutes. What to do? Here we need to remember that additional IM doses of epinephrine up to 3 doses can be given, and even intravenous epinephrine is given if IM epinephrine doses are not enough to achieve significant symptom resolution. When intravenous epinephrine is required, slow infusion is preferred to bolus dosing due to the risk of cardiovascular side effects, example, ventricular arrhythmias, myocardial infarction. Patient in perioperative settings presents with increased peak inspiratory pressure, B/L wheeze, and decreased end tidal carbon dioxide after anesthesia administration. What does it indicate? So here we should get an idea that there is anaphylaxis to some drug given in the preoperative setting, usually anesthetic. The complicated words here are increased peak inspiratory pressure, which means some obstruction is happening such as bronchospasm leading to increased PEEP. Decreased end tidal carbon dioxide is an indicator of decreased cardiac output or decreased CO2 delivery to lungs. Looking for the skin manifestations is important in the perioperative settings as the patient will be usually draped and skin manifestations can be masked. Wrong intubation can also come into your mind as it came into my mind, as it can also be a common reason of acute difficulty in breathing post-intubation, but presence B/L breath sounds excludes wrong intubation. Few points regarding the criteria for hospital admission that you need to know include: patients with protracted anaphylaxis, that is symptoms lasting hours to days, despite treatment, should be admitted. Severe symptoms such as hypotension, upper airway edema, respiratory distress occurred at presentation, and patient requiring multiple doses of epinephrine to achieve symptom resolution requires hospital admission. The below two patients are believed to have a higher risk of biphasic anaphylaxis, that is recurrence of symptoms after an initial period of resolution. Risk factors for fatal anaphylaxis include older age, asthma, cardiovascular comorbidities, and delayed administration of epinephrine. Patient presents to ER with skin rashes and wheezing but normal vitals. What do you think the diagnosis? I want you to remember the diagnostic criteria for anaphylaxis, and also remember that hypotension is not required to make the diagnosis. It can be some other two systems involvement, such as gastrointestinal and skin, or gastrointestinal and respiratory tract. Pause the video and review the diagnostic criteria for anaphylaxis. A child with AH/O fever 101 degree Fahrenheit during previous DTAP and family H/O seizures. Is DTAP contraindicated? Absolute contraindications for DTAP vaccination are to be also remembered, as said before. Absolute contraindications for DTAP include anaphylaxis immediately after the vaccination, which is a contraindication of any vaccination. Encephalopathy within 7 days of previous vaccination, if occurred, is due to pertussis components, and so children can no longer receive pertussis immunization, but can still receive tetanus and diphtheria toxoid (TD) vaccines. A child with a otitis media infection on antibiotics and with pregnant mother in the house. Is MMR vaccine contraindicated? As stressed before, vaccine contraindications can be asked. Contraindications are anaphylaxis presentation, such as respiratory compromise, hypotension, angioedema to neomycin or gelatin, which are components of the vaccine, or after prior administration of the MMR vaccine. Pregnancy immunodeficient patients, HIV with CD4 200/MM3, congenital immunodeficiency, or hematologic/solid tumors. Household contacts of the patients, including children of pregnant women, can safely receive live vaccines. A patient on a number of drugs presenting with self-limiting facial swelling with prominent lip and tongue swelling and dry cough. What drug is coming in your mind? Patient on a number of drugs presenting with self-limiting, that means disappearing within 24 hours. Facial swelling with prominent lip and tongue swelling, as in this patient, are consistent with angioedema. Patients can also present with abdominal pain due to intestinal swelling. Look for a ACE inhibitor in the drugs, prils. Angioedema associated with ACE inhibitors is usually self-limited, lasts 24 to 48 hours, and, unlike allergic angioedema, is not associated with itching or urticaria. Half of all cases of ACE inhibitor-related angioedema occur in the first few weeks of therapy, although it can occur even in patients who have been on the medication for several years. So do not exclude the ACE inhibitor-associated reaction if the presentation occurs in a patient on chronic treatment. Angiotensin receptor blockers, ARBs, are generally used as a replacement. A 14-year-old boy who is sexually active and uses condoms. Is the HPV vaccine indicated? HPV vaccination guidelines have to be remembered. All female and male patients aged 11 to 26, but may be given to those as early as 9 years and can be given up to age of 45 years. But after the age of 26, the efficacy of the vaccine decreases as the patient is most likely already exposed to the HPV virus. Including those with a history of genital warts, abnormal pap cytology, or positive human papillomavirus DNA test, can be given HPV vaccination. Vaccination in girls reduces the risk for cervical cancer, and when given in boys, it decreases the risk for anogenital and oropharyngeal cancers and provides herd immunity against cervical cancer in women. Genital warts are prevented in both sexes with vaccination. A newborn child with strong family H/O atopic dermatitis. What can be done to decrease the risk of development in her? Normally, the newborn immunity is polarized toward a Th2 response, but can be balanced by a Th1 cytokine profile due to exposure to viral/bacterial microorganisms such as early childhood exposure to daycare, farm animals, and household dogs. So, with early exposure, we are bringing the Th1 response up and there by balancing with the dominant Th2 response, which is the culprit for IgA production. And so the protective factor for development includes shifting the adaptive immune response away from a Th2 predominance, which leads to decreased IgA production and mast cell and eosinophil recruitment. Breastfeeding and emollient application, to protect the skin barrier, also have some evidence of reducing the risk. I welcome any feedback or suggestions for improvements. Thank you for watching, and I hope the video is helpful. And lastly, like, share, and subscribe to my channel. Bye. Meet you soon again. For the PDF of the PPT, go to the website link in the description below. Bye. Until the next video.